Okay, so hello everyone, so we're now going to do a video on closing the wound with primary intention or delayed primary intention. For this video we're going to be focusing on suturing, and James is just going to run through, first of all, giving local anaesthetic.
Okay, so we've got our local anaesthetic here. We just need to check that it is what we think it is. In this case, lignocaine 1% for injection. We need to check that the packaging is intact, that the expiry date hasn't passed. And
route.
Yeah, the route for administration. Yeah, good point. So for subcut, IM use, so that's absolutely fine. So I'm just going to pop the cap off that. Then we need to draw that up into our syringe. Ordinarily we'd label that syringe so that we know what we've got in it, but in this entire procedure it's going to be the only syringe of anything, so I'm not going to do that. And a drawing up needle. I'm doing that.
Sometimes lignocaine is available in a glass vial or in a plastic vial. If it's a plastic vial, just use a normal drawing up needle. If it's a glass vial, you should use a drawing up needle with a filter on it.
There we are, so we've drawn up.
I'm just going to grab sharps with wonderful system.
And then we'll just attach our fine gauge needle. And put that into the tray. Okay, you would need to work out the maximum dose of lignocaine. There are two common concentrations, 1%, 2%. For the purpose of suturing, 1% is more than enough. And with 2%, all you do is run the risk of giving them an overdose with a much smaller volume, and it doesn't give any better anaesthesia to the tissue, so 1% is definitely the thing to stick with. And if you look in your books, there will be a guide where you can work out the maximum dose. But for something like this, there is no way we're going to approach the maximum dose of lignocaine to close this. There are different ways of injecting the local anaesthetic. You can inject into the raw edge of the wound and then use a fanning motion to just infiltrate the local anaesthetic. There's a really good picture of that in your practical skills book. Alternatively, you can run the needle into the margins of the wound and infiltrate the local anaesthetic as you're drawing back the needle, and then realign the needle and then run along the other margin of the wound, kind of in an in direction, draw back and then realign and go forward. That's equally acceptable, and it allows you to infiltrate that local anaesthetic into the tissue. Or alternatively, you can go in on the intact skin and infiltrate, and then with a fanning motion, using the needle in kind of a fanning direction, you can infiltrate into the various parts of the margin of the wound, and then move along a bit and give another injection into the skin through infiltrate. With that technique, you do tend to end up with a few more little pin pricks around the wound. So that's just something to bear in mind. But yeah, that's the different techniques. So I'm going to pop my gloves on now. This video, we're just going to assume that the wound has already been examined, explored, cleaned. And don't forget that as keen as we are to put sutures into wounds, because it's a really nice practical skill to perform, it's actually the very last thing that we do on our patient's wound management journey, because at that point we're closing the wound and then potentially sending them off home. So everything has got to be done before that point: the exploration, the cleaning, the imaging if need be. So this is the very last thing that's done. So if we take our local anaesthetic in our syringe, it's the only solution we're using, so it isn't labelled, but it's the same stuff that I put there a moment ago. So I would now just explain to the patient what I'm going to do. If I've given it all a good clean up, which I would have done, then the drape may be in position already. If it's going to be particularly awkward, you may choose to put the local anaesthetic in without a bigger drape, because you're not worried about the suture material itself dragging along tissue. that isn't sterile, because actually the only part of this thinking of RANTT that needs to be sterile is the tip of the needle that's going into the tissue. So the fact that I might rest my hand on their arm is really immaterial. So I'm going to just pop this local anaesthetic into the tissue, just warn the patient what's about to happen. So you're just going to feel me passing that needle in, and I'm now going to infiltrate along that left margin, and then I'm going to readjust the direction of my needle, pop the needle in again, and now infiltrate. So I've now infiltrated local anaesthetic into this margin and this margin, so a bit like a V shape, a V formation. I would then move myself around the other side of the patient, but thankfully due to this camera work I can just move the patient very easily, and so I would then inject again and just along the wound margin and infiltrate as I withdraw, and then realign it and then infiltrate as I withdraw. So now I've injected the local anaesthetic into the wound along this margin, this margin, this margin and this margin, and now I need to give that some time to work. It's very little benefit to the patient if you can put 3 or 4 stitches in and then the area actually becomes numb, because they will have endured that discomfort. So just allow it to take some time. It can take a few minutes to take effect, and you can just test that by asking the patient if they can feel any sensation if you just give the wound a prick with that sterile needle, and they can report that that's now nicely anaesthetised.
Does it sting as it goes in?
It can do. Some things that you can do to have an impact on that is, obviously, if you're forcing a lot of the local anaesthetic in very quickly, you've got the displacement of the tissue with the lignocaine, which is going to be uncomfortable. If you spend too much time wiggling around a lot with the tip of the needle actually in the tissue, without giving much local anaesthetic, that's uncomfortable. And actually there's a lot to be said for warming the solution just before you crack the container open, obviously, just in some warm water. You can just warm it up a bit so it isn't actually cold. That reduces the discomfort felt by the patient. But if you're careful and take your time and just do things sensibly, very quickly the patient understands what's going on. And I often say to people that, you know, when you feel the stinging, if you feel any, that's a sign that the local anaesthetic is starting to work. And if you then sort of mentally count down over perhaps 30 or 40 seconds, by the time you get to 0, that stinging effect will be much, much less. And often, you know, they don't get down to the 0 before they say, actually, it's a lot more comfortable. So really, it's about managing their expectation, you know, just allowing the stinging may start, but it will rapidly subside.
Excellent. So
we'll see that that's now taken effect, and we've tested it with the needle to make sure that it is actually all anaesthetised. So now I'm going to take my drape, I'm going to apply it over the wound, and this is now going to help with my asepsis. I'll put some more gloves on. So now that I've got the thread, could actually rest onto this field without worrying about becoming contaminated.
Okay, that's excellent. So what we'll do there is we'll pause the video there, and then we're going to do another video, and that will be actually showing the actual suturing. Thank you very much.